So what are symptomatic patients? TIA, transient monocular blindness in the referable carotid, minor non-disabling strokes in the previous 4 to 6 months. And so if you looked at these pooled analysis of a variety of different trials that looked at symptomatic disease, I tried to highlight if you have near occlusion, if you have stenosis less than 50%, there's no benefit of doing anything surgical. If you have stenosis of less than 30% and they have symptoms ipsilateral, you may actually be harming patients. So the degree of stenosis directly tells us the risk of the procedure and the benefit. So the key kind of patients we want to think about doing something for or recommending something be done, greater than 70% stenosis is one type of patient. 50 to 69% stenosis is another type of patient. So what if you have a patient that's moderate medical risk or high risk for surgery and they have 50 to 69% stenosis on ultrasound? Maybe you want to get another study like a CT or MR, or if they're 70%, so it can affect your decision whether to refer patients for surgery or not. So if you have, this is what was kind of disturbing to me. I like these kind of numbers. So if you have greater than 70% symptomatic stenosis and you do revascularization with carotid endarterectomy, you need to treat, so this is NNT, this is one of my favorite things to look at, how many strokes, you're going to prevent 1 stroke in 5 years if you do 6 carotid endarterectomies. So you have to do 6 carotid endarterectomies to prevent 1 stroke in 5 years for greater than 70% symptomatic stenosis. Absolute risk reduction of 16%. What if you have a symptomatic patient with 50 to 69% stenosis? Number needed to treat to prevent 1 stroke in 5 years is 22 patients. So when you have these patients with moderate degree of stenosis, even if they have symptoms, those are patients we want to really think about is the risk of the procedure exceed the risk of the disease process. Absolute risk reduction of 4%. So symptomatic patients, the indication for surgery is recently symptomatic, 70 to 99%. So just remember that, 70 to 90%. You want to make sure the patient has life expectancy of greater than 5 years, and carotid endarterectomy is recommended over medical therapy alone. What about the timing? This always comes up. The patient came to the hospital, they had a stroke. When should we do the surgery? So generally, proceduralists, interventionalist surgeons, they don't like doing stuff to people who just had a stroke. So we always want to wait 6 weeks. Unfortunately, if procedures are not done quick enough, the patient could have another stroke and they've missed the benefit of the procedure. So observational evidence suggests that probably shouldn't do anything to the carotid lesion in the first 48 hours. And probably if you don't wait more than 2 weeks, you're missing the opportunity to prevent another event. So surgery, timing of surgery, 2 days to 2 weeks. What about the difference between men and women? For men, if you have a life expectancy greater than 5 years, and they have 50 to 69% stenosis, surgery is probably better than medical therapy at this point. What about women? This was one I did not know, to be honest with you, is that women between 50 to 69%, American Heart Association guidelines suggest that medical management is probably better than endarterectomy in this subset of patients. And each patient is different and have to be evaluated, but something I didn't know was a guideline. What about carotid artery stenting? Indications, these patients have to be symptomatic. So I basically do not offer carotid artery stenting unless the patient has symptoms. They have to have greater than 80% stenosis, and they cannot be a surgical candidate. So there's lots of trials that are coming out saying that there's equivalency for carotid artery stenting and carotid endarterectomy once you get past the first 30 days, and I agree with those studies. But at this point, CMS will not pay for, and most insurances will not pay for any carotid stents put in an asymptomatic patient with less than 80% stenosis, even if it's 79, that's why another study might be helpful. And they have to be evaluated or deemed not a surgical candidate. So carotid endarterectomy is generally recommended over carotid artery stenosis if you can get to the lesion. So if the lesion's high, then that's a good stenting patient. They should probably have an absence of significant cardiac, pulmonary, or major medical comorbidities, and you have to think of the increased risk of surgery if you need general anesthesia. And generally, if they've had a previous carotid endarterectomy, then those are probably patients that are better served with a stent because of the risk of scarring and causing nerve injury and specifically hoarseness and vocal cord paralysis. Carotid artery stenting over carotid endarterectomy just in patients that are deemed not good surgical candidates, radiation-induced stenosis, absence of clinically significant comorbidities, and if they've had restenosis after prior. So what are some additional factors? This is kind of flipped like crest basically reversed our approach to this, that if you have an older patient, we should probably stent them. And what we've found over the last several trials is that older patients greater than 70, they probably have less complications with surgery rather than stenting. I always thought of older patients, let's do something minimally invasive, but getting to the correct place, and it's probably higher risk. If you have a hemispheric TIA, meaning you have a global hypoperfusion, those patients probably benefit from carotid endarterectomy rather than transient retinal ischemia. So if you have a big TIA versus a very minor one, those are patients that probably benefit. If you have severe contralateral ICA stenosis or occlusion, you should still consider repairing the ipsilateral side, meaning with that shunt. Carotid endarterectomy is not beneficial for near occlusion of symptomatic ipsilateral carotid internal carotid stenosis. Let me just say that last one again, because this is one that I probably get asked once a month. This patient has like 95% or 99% occlusion. Should we revascularize them? Most data would say no. So this is another one where we see a string sign. Why do we say no? Basically, the blood flow to the brain from a 99% stenosis is probably close to zero. So by revascularizing them, you're probably not going to add much. And imagine the difficulty of trying to, sew a 2 millimeter vessel to like an 8 millimeter vessel. It's not that easy. So these are patients maybe medical management would be lower risk and probably yield a similar outcome. So what exactly is stent-assisted angioplasty? So what we do for these patients generally is they're awake under a little bit of local sedation, so numb the leg, put a plastic tube into the leg, and take it from the leg into the neck. So that's what this arrow represents, the plastic tube in the neck. We use the x-rays to watch a wire, and this wire is about 3 times the thickness of a human hair, and we try to get that wire to go from this plastic tube across the area of narrowing. And it usually goes pretty smoothly, but there are times where you cannot cross the lesion. The next thing we do is once we get that across, we put up a filter, which is kind of like an upside down colander, and it catches any debris while we're working. And then a stent is placed, so you can see the beginning of a stent. And this is what the stent looks like once it's deployed. Once the stent is deployed, there's still this area of narrowing because of all this plaque. And then we go back and inflate it with a balloon. So this is stent-assisted angioplasty, means the stent is keeping the vessel open once the balloon stretches the plaque out. So what are some things I don't like about stenting? The plaque isn't removed. The plaque is wedged up against the wall. Generally works very smoothly, but you can imagine if pieces break off and go to the brain, you can have strokes. So the stroke rate is generally less than 3% for asymptomatic and less than 5% for symptomatic patients. But we're always trying to say, is the benefit of this procedure worth it for a patient that's maybe 85 years old and has an asymptomatic lesion? So this is a very typical case that I get referred, 73-year-old, symptomatic recurrent carotid stenosis after prior carotid endarterectomy. So what are some of the key things here? The patient's 73, so they're a little bit older for stenting versus surgery. They are symptomatic. They have recurrent stenosis, and they've already had a carotid endarterectomy. So this is somebody who would say, oh, maybe we could help them. So then when we're looking at the blood vessel, so here's the common carotid artery, here's the internal carotid artery, and you can see clearly where the narrowing is and the normal blood vessel. Let's see here. And so I just subtracted it, meaning you can see all the bone and the metal. You can see all these clips from the prior carotid endarterectomy. And so what we do is place a stent. So first thing we do is place this filter, which is this blue arrow, which is that upside down colander. And the second thing we do is here's the distal end of the stent in the yellow, the proximal end of the stent in the yellow, and here's the expanded balloon pinning and opening up that stent. So this is the lesion before. I kind of outlined it to make sure everybody kind of sees the normal vessel, distal and proximal, and the area of stenosis, and this is what the lesion looks like after. I would say on average from the time we put the plastic tube here to the time we put the filter and do this, on average is about 6 to 8 minutes is what it's taking. So this whole procedure may be 40 minutes. All of the real work is trying to pick the patients that would actually benefit. And so, I'm actually obsessed with what's going on in the brain, not so much the neck. And this is the blood flow to the brain before revascularization. And so this is the internal carotid artery. This is the middle cerebral artery. And I do not see the anterior cerebral artery prior to stent placement. Once the stent's placed, then there's improved flow to the brain. And the thing I'm always very worried about is, did I break off a little piece of clot and did it go to the brain? And so we're we're talking to the patient, examining the patient during each of the steps, and then we're looking for any blockages that occur, and again, pretty infrequent. So just to finish, so we can stay on time, the keys that I just want you to remember, if you can, is that carotid disease is a very important cause of stroke. Most people would say 15% of strokes are caused by large vessel proximal disease. Asymptomatic patients, at this point, medical management is probably superior to surgery, including carotid artery stenting. Symptomatic disease, less than 70%. Surgery, carotid endarterectomy in men is probably better than medical management alone. Symptomatic disease greater than 70%, carotid endarterectomy, again, is the recommended treatment of choice. And keep those numbers in mind, number needed to treat. So you have to treat 5 or 6 patients for at least 5 years to prevent one stroke in this subset of patient, where in this less than 70%, you're treating like 20 patients. And then finally, carotid artery stenting is now only indicated if you have greater than 80% stenosis, symptomatic, and these patients are deemed non-surgical candidates. So I'm just going to end there, and I'm happy to take questions if we had time, but I hope that was a good simplified overview of this constantly moving target, which I find challenging myself.